What's going on, everybody? Dr. Chad Woolner here with my good friend, Dr. Jared Armstrong. This is episode 43 of the Health Fundamentals podcast. And on today's episode, we're going to be talking about when surgery is necessary. So let's get started.
Listening to the Health Fundamentals podcast. I'm Dr. Chad Woolner.
And I'm Dr. Buddy Allen. And this show is about giving you the simple but powerful cutting-edge tools you need to change your health and your life.
So sit back and enjoy the show as we show you the path to your best life down to a science.
So hey everybody, welcome to the show. We have a special guest with us today, my good friend, Dr. Jared Armstrong. Thanks for being here with us.
You're welcome.
Appreciate you taking time out of your schedule. I know you're crazy. You said you just got done with was it 17-day shift?
Yes. Yes, too many days in a row.
Yes, so it's probably nice for you to take a little bit of a breather here, so we appreciate you being here with us. And Dr. Armstrong is an orthopedic surgeon. We've known each other for a little while now, and I thought it would be a really good opportunity for us to have this discussion here because, quite frankly, you know, for those who listen to the podcast, we typically talk about helping patients avoid surgery. But the fundamental truth is, and this is something we really try and share, is that sometimes it's a necessary thing. And so what we wanted to do is really have an expert in this area weigh in on it and kind of share some of his insights in terms of his obviously expertise and experience. And so maybe the best place for us to get started is just tell us a little about yourself, maybe your background, what got you into surgery, and how'd you wind up where you're at today?
Gotcha. Okay, so I was born and raised in Salt Lake. I was a pretty active little kid, got hurt a lot as a kid. Spent a lot of time in the doctor's offices, broken bones, lots of stitches. Just got used to it, and I kind of liked it. As far as not getting hurt, but like
the experience.
I enjoyed watching the doctor fix me.
Yeah.
And the result.
Yeah.
And I decided that's what I wanted to do.
That's
since
awesome.
I was about 8 years old, I wanted to be a doctor. So.
That's awesome. And I know you and I have a special bond in that we share a near drowning experience, but you had a near death drowning experience. I had a near death drowning experience. Yeah. Talked about that.
That was miserable.
Yeah.
For anybody who's ever near drowned, it's miserable. It's not a fun.
Very traumatic. Very traumatic.
So I was on Bear Lake when I was 22. I'm a good swimmer, so I swam in high school.
Yeah.
I can swim 4 or 5 miles in a row, no problem.
Yeah.
Got out on this lake in the middle of a storm, chasing a boat that had kind of moved away from shore.
Yikes.
And the water's cold there for people who have been to Bear Lake. It was early in the season. It was cold water. I got about a mile out into that lake, and it was hypothermic. And there was nobody out there to help me.
What season? Was this spring? Summer?
It was late spring.
Okay.
Yeah, early summer.
Yeah.
And it was still cold up there. It was still, I think it was kind of a cold winter that year, but
sure.
Decided to swim back to shore, but realized I wasn't going to make it to the boat and I wasn't going to make it back to shore. So I got really lucky. Somebody saw me and came and got me. So
yikes, scary. So you got beat up a lot as a kid, lots of cuts, lots of stitches, broken bones as well.
Mm-hmm.
Broken bones, the whole 9 yards, everything. 8 years old, you decided you want to be a doctor. So then, where did you wind up going to medical school?
So I went to the University of Louisville Medical School in Louisville, Kentucky.
Okay.
Stayed there and did my residency. So that's 5 years beyond medical school. So
okay.
I did undergrad of 4 years, bachelor's degree, 4 years of medical school, 5 years of residency there in Louisville again.
Okay.
And then I did a fellowship in Phoenix for hip and knee replacement.
Okay. Now, when you were in medical school, did you know pretty soon that you wanted to be an orthopedic surgeon?
So initially I wanted to be a cardiothoracic surgeon.
Okay.
And then my first year of medical school, I went down to Honduras to do a surgical kind of rotation down there for a month. And it was in this small town in Honduras called El Progreso.
Okay.
And I was assigned to some general surgeons down there, and they operated on Monday, Wednesday, and Friday in their OR. They only had 2 ORs.
Okay.
In this tiny little hospital. And the orthopedic surgeon had Tuesdays and Thursdays. And after about a week or so, the general surgeons told me, said, hey, why don't you go with the orthopedic guy? And so I did.
How far into med school were you at this point?
I was between my first and second year.
Okay.
So I went and followed the orthopedic surgeon around. And the orthopedic surgeon, his name is Dr. Chinchilla. He was the funnest guy you've ever met. And he let me do a ton of stuff.
Yeah.
And it was, I loved it.
Yeah.
and loved it more than the general surgery side, doing appendectomies and cholecystectomies and bowel surgeries, and the trauma stuff on the orthopedic side was just exciting and fun.
Yeah.
He let me do a ton, and I loved it. I was hooked from that day.
What sorts of things were you seeing down there?
In terms of general surgery or orthopedic surgery?
Orthopedic.
That was usually kids falling out of trees and breaking their arms, or
Okay.
there was occasional gunshot wounds that we would see, but really it was blunt force trauma kind of thing.
Okay. And I would imagine, if the gunshot was to bone and or joint, you're going to be pretty heavy involved in that process in terms of surgeries there.
Yeah,
as an orthopod.
So the general surgeons, there was a couple days I would do general surgery where the guy would have been caught in a fight with a machete, and he had an abdominal wound with a machete, so we were fixing his bowels. And then the next day we were taking care of his orthopedic injury where he had his arm broken during the same fight.
Holy cow. That's crazy. I take it you don't see a whole lot of that here in town, machete wounds that you need to...
Machete wounds are not real common. I don't do a lot of trauma here, but in residency, I did a ton of trauma.
Okay.
And I saw all kinds of... It was a knife and gun club, and it was... Yeah, and a lot of ATV accidents, motorcycles.
Okay.
Yeah, I'll never ride a motorcycle on the street ever in my life.
Really?
Yeah, it's bad.
My father is a semi-retired, I should say, registered nurse, and he's worked in just about every department you could imagine. And I grew up always referring to motorcycles as donor cycles. That's what my dad always referred to them as, because they're just...
They really are. But there's not a lot left to be donated after a motorcycle accident. They're awful.
Right. It's pretty scary
They
stuff.
mangle you pretty good.
Yeah, I'd say so. So, what do you love most about what you do? I mean, obviously you do a lot of, hip and knee. That's what you've specialized in. What do you love most about this whole process?
I don't know. There's a lot of things I like.
Yeah.
I like seeing patients get better.
Yeah.
It's pretty predictable too.
Yeah.
98% of patients that come in having really hard time doing normal activities like getting in and out of their car, putting on their shoes and socks. They have a hard time. And then, a couple weeks after surgery, they're singing your praises. Some people even, start crying because they're doing so much better. And it's very predictable.
Yeah. That's super rewarding. And it's nice to hear that because, coming at it from the perspective of me as a chiropractor, we obviously don't do surgery, and our attempt is to try and help people avoid that road. And those are the same, what you just said, there's the same reason why we love what we do, right? Helping make a difference. And it's nice to hear that because it's sometimes in the healthcare space, things can be pretty divisive, in terms of territorial, and we do this and we do it better. And the thing I think it's important to kind of step back, and I don't mean for this to sound terribly kumbaya, but it's just nice to know that everybody's coming at it with the same intent and purpose, or at least we hope most are, that they're really trying to make a positive difference in patients' lives. And so that's good to hear that. What would you say are some of the biggest misconceptions perhaps about orthopedic surgery and or orthopedic surgeons that you've heard?
Probably the biggest complaint that I hear about orthopedic surgeons is, hey, you're a hammer, and when you're a hammer, the whole world is a nail.
Right.
So, you're a surgeon, you figure you can fix everything with surgery. And that's not true.
Yeah.
A lot of patients come into clinic and I tell them you don't need surgery.
Yeah.
And I know that's true for a lot of orthopedic surgeons.
Yeah.
Now there's occasional doctors here and there that are struggling for money, and they're starved for a little bit. And so maybe they'll blur the line of, you need surgery and you don't. They're operating on those borderline patients.
Yeah.
But that's not real common. I think the grand majority of doctors are pretty good about indications, but there's a few out there that...
Yeah. And that's all it takes. That's the unfortunate thing, right? It only takes a small handful to really it's the classic, one bad apple can really spoil the bunch. And it's no different with our profession as well. Same sort of idea. For those who don't live here in the Treasure Valley, Dr. Armstrong, I'm going to brag on you for just a second. He's got a stellar reputation. In fact, one of his kind of things that he's very well known for is kind of the fix-it guy, in the sense that you're kind of the either second opinion guy and or after the fact, if somebody has had a surgery that hasn't gone very well, you see a lot of those cases too. Is that correct?
Yes, I did a fellowship to do that. That's part of what I did for a fellowship, was fixing revision surgeries, we call it.
Okay.
And that's fixing previous total hips and total knees that have not gone to plan.
Okay.
Which unfortunately happens more often than we'd like.
Yeah.
But it happens.
What are some of the common mistakes in terms of that would lead to that to where people, is it just like they didn't measure it correctly, or was it just not foreseeable? I mean,
some are foreseeable, some are not.
Okay.
So with hips, the most common is that I see is either dislocation or infection.
okay.
The third would probably be a fracture. That's
Okay.
not foreseeable, typically. But in dislocation, sometimes that's foreseeable, sometimes it's not.
Sure.
Patients who have had previous spine fusions are at a very high risk for dislocation,
Okay.
and there's not a lot you can really do for that. You can try to change the orientation of the cup and the pelvis, or change the orientation of the stem and the femur.
So people who have had their spine fused, it's going to alter the mechanics of the hip itself. That's a risk factor.
Yes. So when your spine is fused, the motion that you have to have for daily living has to come from somewhere.
Sure.
And if it's not coming from your lumbar spine, it has to come from your hips
Okay.
in order to stand up straight. So you have to extend your pelvis more. And when you do that, it puts your hip at a greater risk for dislocation.
Okay.
And so just some patients that have had spine fusion are at
Yeah.
higher risk for dislocating their hips. So
Okay.
just talk to your surgeon about that.
Yeah.
There's different things you can do to mitigate that risk.
Sure. So in terms of surgery, the real question that we want to try as best we can to answer, because again, for patients who are, or people who are listening to this podcast, what we're trying to provide for them is a really good resource for them that maybe there are people who are contemplating surgery. And so maybe, again, from your lens and from your area of expertise, maybe making that or helping to provide a little bit of clarity for them in terms of like feeling confident in that decision, because I think that's one of the scariest things, when somebody's making that decision, but they're not quite confident in it, and they're always second guessing, did I make the right decision? Is this really something I should? So from your area of expertise and your lens, what are some general guidelines that people can go by in terms of knowing, like, yes, surgery is necessary here in these types of situations from your and I know that's kind of a broad-based question, but in general, there are some kind of ideas that people can kind of think of in those terms.
So that's probably the most common question I get asked in clinic, anywhere else is, do I need surgery?
Yeah.
And that's kind of a tough question to answer.
Sure.
I always tell my patients that's a question you answer, not a question I answer.
Right.
I think it comes down to, so what I do is typically an elective procedure. You do not have to have a hip replacement or a knee replacement to live.
Sure.
You just don't have to. You choose whether or not you're going to get it or not.
Yeah.
And that's different for everybody. I think quality of life is what we're trying to replace here.
Sure.
And I tell my patients, look, when you have failed conservative management, and there are certain things that when conservative management show good evidence,
Yes.
some that don't.
Yeah.
So I think if you try the ones that show good evidence and you still are not able to maintain your quality of life,
Yeah.
the important things that are important to you, like if you enjoy going on walks with your spouse and you are no longer able to go on walks, or you dread those walks because you're going to have so much pain afterwards, then it's time to do something.
Right.
But let's say, for example, you play basketball, but you'd be willing to give up basketball. Like, it's not that important to you.
Right.
Maybe give up basketball before you pursue surgery.
Right.
But if it is really important to you, maybe you should, and you're going to have to give it up because of the pain, maybe it's time to get surgery.
Yeah. How would you define failed conservative, right? Because we see a lot of times patients who come to us who sometimes patients, they want it. They want surgery, and they'll say like, oh, I've already tried chiropractic and or physical therapy. And when you really kind of dig in and tease that out, it's like, I went twice and it didn't help me. And we're like, well, that's not realistic, in terms of us thinking that conservative management is going to fix this problem, or at least help you to the degree that it could help you in 2 visits or 3 visits or whatever. So from your perspective, when would you say like, yeah, they've really tried and given it an honest shot in terms of conservative management, and that's just clearly isn't going anywhere? What would you say?
That's a good question. Hard to answer.
Yeah.
So for me, for knees, I want them to fail injections.
Okay.
Corticosteroid injections.
Okay.
I don't care if they've tried any other injections, but corticosteroid injections are the best option for injections that we have, the best evidence that we have for injections improving symptoms. So they have to have failed that.
Yeah.
And then they have to have failed activity modifications, meaning that they've tried to do some other things and avoid certain activities that irritate it. And I think that's important to try. I don't. There's good evidence for weight loss with knees.
Sure.
But there's some patients that they try to lose weight or aren't motivated enough to lose weight. But even heavier patients, to a limit, get good benefit from a knee replacement. So
Sure.
I make them lose weight. I typically make them, meet me halfway.
Sure.
If they've tried before but haven't been able to, I make them lose some.
Sure.
Hip replacement patients, there's really only two good options for hip arthritis as far as conservative management, and that's medication and surgery. Weight loss doesn't seem to help.
Okay.
Things like crutches, walkers, braces don't seem to help. Injections are typically short-lived and are hard to do because you have to do it under ultrasound. They're expensive.
Right.
It's about an $800 thing for a hip injection, and sometimes they only last for 2 weeks.
Right.
And most people wouldn't pay $800 for 2 weeks of relief.
Right.
So that's a big ask for some people with stretched pocketbooks. So that's probably what I'd ask. They failed medication and they failed activity modification.
Sure.
So it's different for each person.
Sure.
I don't think I'd make a person go a year of conservative management because you ask somebody that can barely walk or sleep to go a year without sleep or a year without getting out of their car, they have to have their spouse put on their shoes and socks. That's a long time.
Yeah, that's a pretty big ask for a patient.
Yeah, they get muscle atrophy with prolonged inactivity. You're causing other health problems.
Yeah. Our experience that I've come to find is I try and be pretty reasonable, I guess is the term I would say, in the sense that while, I always, and this is a very common, because we see a lot of patients in our clinic who have problems that are chronic in nature, right? They come into us and they're like, oh, this is, my back goes out every time this year or something like that, where it's like, there's a clear pattern that's been going on for 10 years. And so this is a very common line for me where I'll say to them, look, it's highly unrealistic that we're going to fix a 10-year problem in 2 or 3 visits, right? And that's a very common kind of, I think sometimes misconception that people will have is just crack my back 2 or 3 times and hope it goes away. And the reality of it is that we always say, look, if there's a spectrum, there's an over-treatment and then there's certainly an under-treatment realm, and we need to find kind of that middle ground. And we always tell patients, we don't put patients on year-long care plans at our clinic, but at the same token, we got to hit this consistently. There's no substitute for that consistency. We have to be consistent somewhere in there. And so for us, in terms of that, for us, we typically will say, look, if you've been seeing us consistently and you've been doing everything on your end for 3 to, let's say, 6 weeks, and you're seeing no difference not only in symptoms, but we're also not seeing any objective difference in terms of objective outcomes that we're measuring, whether that's strength and coordination, balance and stability, et cetera, flexibility, all those different areas. Those are typically good indications that either A, what we're doing isn't helping or working, B, we need to significantly modify, change something, or C, perhaps it is time for us to start looking at more invasive options there, maybe even surgery is the thing that we need to start looking at. So that's kind of from our perspective where we come there. Would you have a stance or a take on what's going on right now with regenerative medicine? Any?
Yes. I don't know that many of the people who are listening to this podcast will agree with me.
That's okay. Hey, and here's the point. I'm glad that you're here and I'm glad you're shedding, because again, I think this is important because there are different perspectives, and I think that's totally okay, and it's totally okay to disagree. It really is. So, I mean, in terms of that, I really would like to hear what even if it is a different opinion and or something that people may not necessarily want to hear. So
yeah. So
speak freely. You're in a safe zone, my friend.
So in terms of stem cells, is that specifically what we're referring to?
Anything, because again, under that umbrella of regenerative, there's a lot of different things that are happening right now, and I know there's a lot of pretty significant claims. We've talked about it on the podcast in terms of either stem cell therapy or some of the other things.
Yeah. So I think you have to tread really lightly with the stem cell issue.
Yeah.
One, it's not FDA approved. So, and there's several reasons for that. Not that I think the FDA needs to approve everything.
Right.
There's things I do that are not FDA approved as well.
Sure.
Like a lot of the drugs we use are off-label. Like
sure.
I give aspirin for indications other than what's FDA approved for it.
Right.
Which is okay. I mean, that's my prerogative as a medical doctor. I can prescribe things for different reasons. And
sure.
We use a drug called tranexamic acid off-label, and that's widely accepted in all of surgery.
Yeah.
But in terms of stem cell, the problem is that there's not very good evidence for it yet.
Yeah.
So I'd be hesitant to to be giving it to everybody, especially because it is very expensive. The average, I think there was a study in Florida that showed the average cost for a stem cell injection that they were, for the 100 orthopedic surgeons in this county in Florida, was like $4,600 for a stem cell injection. And there's no evidence for it.
Right. Well, and I think sorry to interrupt, I was just going to say, I think part of the problem too is that it's difficult to define even that term stem cell because of the source in which you're deriving them from. And then also, are we even dealing with real, actual live stem cells?
Yeah, exactly. You've got adipose derived, you've got bone marrow derived, you've got cord
blood. Yeah,
blood.
Exactly.
The problem is that there's no standard definition.
Correct.
There's no standard dose or strength.
Yes.
There's no, and then the FDA has certain rules for any, like when you spin it down, there's certain things you cannot do to them. Otherwise, you're violating the FDA's rules on stem cell manipulation.
Right.
And you can get yourself into legal trouble doing that too.
And there's been a lot of that there's been a lot of, like, with a lot of integrated clinics, there's been a ton of cracking down and things like that.
And you have to be careful on how you advertise too, because when you advertise and say, hey, look, this is going to regrow your cartilage,
Right.
This is going to do this is going to improve your pain, but there's no evidence for it, you might be in trouble for false advertising or marketing issues.
Right.
And so because there's no evidence for it, and in terms of risk, there's risk for infection with any injection you give, whether it's saline or whether it's stem cells, whether it's corticosteroids, whatever it is. You have risk for infection. You have risk for injection site reactions. You have risk for the stem cells themselves. So they have been shown to cause tumors. Like stem cells can grow anything they want.
Yeah, and I've heard that.
And so, I mean, they're not risk-free, but there's no proven benefit. So when you look at the risk versus reward, I mean, there's more risk currently than proven reward. So I would hold back until there's more evidence on it. I'm sure there's people doing clinical trials on it now. Just wait for those to come out and then start to do it.
So under that same umbrella, let's just kind of go down the list and get your opinion here in terms of, because we have our opinion. We believe it or not, do kind of share a lot of similar sentiments, just because right now with stem cell, it's very much the wild, wild west. And a lot of marketers, we'll just say it that way, are capitalizing on that. And so I can appreciate that to a certain degree. But at the same token, we want to be above board and beyond reproach in terms of the claims that we're making. But do you have an opinion when it comes to like amniotic tissue, or I think the term a lot of people are using, exosomes, where they're saying it's not stem cell, but it's just growth factors that we're injecting into the area?
Yeah, kind of like PRP or
very so. And that's because we kind of talk about it at our clinic. The two options that we really talk about, we don't really talk a whole lot about stem cell, primarily because of exactly what we just talked about there. It's just there's not a lot of clarity on it. So for us, it's PRP and or amniotic or exosomes, right? Yeah. That's what we use. So I'm curious as to your take on those.
I don't know anything about the exosomes, to be honest. I don't know much about it. I can't really comment on it. PRP, there are things in the PRP, the platelets and whatever that's in the PRP that do have some anti-inflammatory effect.
Sure.
And I think that can help some people.
Sure.
It's being used from everything from tennis elbow injections to, they do a meniscus repair and they stick a little goober from the PRP spin down in there. And,
right.
Does it really help a lot? I don't know. I don't know literature on that.
Yeah.
I know some of the injections do cause some benefit for at least a short period of time.
Sure.
But they've also found some benefit with saline injections.
Sure.
So maybe diluting the inflammatory markers in the knee might benefit the knee a little bit in terms of inflammation. Then there's always the placebo effect.
Absolutely. So. And that's something interesting. Placebo effect has always had such a negative connotation in some circles. I'm all for it. The more we can utilize placebo to help people, the better, And obviously that's not saying that I don't care about what we do or whether or not there's evidence behind it or science behind it. But at the end of the day, I think it's nearly impossible to completely ever eliminate placebo from anything. And so if we collectively as physicians can capitalize on that to the benefit of the patient, because there is also the nocebo effect that we know is the same on the opposite end. And so whatever we can do, there's a new book out, I don't know if you've heard of it before, called Compassionomics. The thesis or the premise of the book is the way the doctor treats the patient has a massive correlation or connection to the patient outcome, right?
I totally believe that.
Yeah, if the doctor's a total jerk, in fact, we did a whole episode on that. Is your doctor a jerk, right? And that was kind of the whole point, is that they've done studies showing doctors who are just great with patients and have better bedside manner get better outcomes. They just do.
I believe that 100%.
So anyhow, dude, we can talk forever, and I already appreciate the fact that you've already given some really, really brilliant insight and very honest insight for patients to kind of consider and contemplate when they're looking at these kind of decisions that they need to make. Any other final thoughts that you would have for patients who maybe either are contemplating surgery, or maybe they're concerned about maybe the opinion that they've gotten from a doctor? Any thoughts at all?
In terms of the doctor, there's not all doctors are equal.
Right.
Not to plug myself, but I do a good job.
Yeah,
there are other
no.
doctors that do as well. There's some doctors that don't.
Yeah.
I'd ask my doctor a couple questions. I'd ask how many they do per year.
Okay.
They need to be doing at least 10 of that procedure per month for you to. I wouldn't consider them unless they're doing at least 10 of that procedure per month. If it's a standard total knee.
Sure.
And then I would ask them what their complication rates are, specifically their infection rates.
Yeah.
If they don't know it, they haven't been watching close enough. So just ask them that.
Yeah. Do you think that would create any sort of potential awkwardness with the patient by asking those, or are these like questions that a surgeon should be prepared to answer with confidence?
Oh no, I'm totally okay with patients asking me how many of these I've done. It's not a hard question for me.
Are there others though that, is that a telltale sign if a surgeon is kind of ruffled by that? Is that kind of a red flag for them, or?
No, not necessarily.
Okay.
If they don't know, that's like my typical answer is they say how many of these have you done? And I say this week or this month or this year.
Right.
And they typically say this year. And I'm like, well, okay, I've done this many.
Yeah.
I typically do about 500 total knees and hips combined in a year.
Yeah.
And that's a decent amount.
Yeah.
It's not the most in town. It's not the least by any means, but.
Yeah, but it's
a
lot of experience.
It's enough that I'm good at what I do.
Yeah. So asking how many they do, complication rates,
Yep.
Anything else that they need to be asking?
I would also make sure the doctor sees you after surgery at some point. I have a PA. My PA sees them, and I have a great PA. He sees them at 2 weeks after surgery. I see them again at 2 months. And then anytime they need to see us, they can come see us.
Sure.
But if a doctor does not see you at least once after surgery at some point, then he only has like his physician extenders see you, like a nurse practitioner or PA. Doesn't seem to care like what happens to you afterwards. I'd be wary about that.
Sure.
Just make sure he sees you at some point.
Oh, that's great.
Before surgery and after surgery.
Yeah, that makes sense. Well, awesome. Well, thank you for taking time out of your schedule to be here with us. For those watching, if you know other people that could benefit from what Dr. Armstrong has shared here, if you guys have questions about this, for those who are in town here, what would be a way for them to get a hold of you and or your team?
I work for St. Luke's Medical Center. I work at St. Luke's Meridian Medical Center. You can find me on the St. Luke's website.
Yeah.
You can also call 706-2663, I think is the orthopedic.
Cool.
706-BONE.
Okay.
Is for the
706. That makes sense. Yeah. Bone. All right. Well, awesome. Well, it's been a pleasure, and it's been awesome getting to chat with you and discuss these things. And again, it's awesome to get a different perspective on these things and be able to share kind of, again, your expertise and your experience and what you've had, because you've certainly had a tremendous amount of experience in this realm. And so thank you again for being with us today. And make sure to like the show, subscribe if you haven't already, and again, share this with others that you feel could benefit. Thanks for watching, guys, or listening, and we'll talk to you later.
Thanks for listening to the Health Fundamentals Podcast. Be sure to subscribe so that you stay in the loop and in the know with all of the cutting-edge health information that we share. If you know other people that could benefit from this information, please share it with them as well. Also, be sure to give us a review. These really help us to ultimately help more people. Last but not least, if you have questions that you want answered live on the show, or if you have ideas for topics that you would like us to cover, please shoot us an email and let us know at info@thehealthfundamentals.com.